Hi, this is Mrs. Lewicki, and this is the third PowerPoint of 5 for the cardiac section. This one's going to focus on heart failure and valves. So heart failure is described as systolic, diastolic, or can be both or mixed. Systolic failure is caused by an impaired contractility, increased afterload, valvular heart disease. The left ventricle is unable to generate enough pressure to eject blood forward through the aorta. The left ventricle becomes dilated and hypertrophied. Hallmark sign of it is decreased ejection fraction. Diastolic failure is the inability of the ventricles to relax and fill. There is a normal ejection fraction. It results in decreased stroke volume and cardiac output. The ventricles become stiff and the filling pressures are high. More frequent in older women and obese patients. Mixed is seen in dilated cardiomyopathy and the dilated left ventricular with poor systolic function. Compensatory mechanism in heart failure is the sympathetic nervous system is activated. It's triggered by low cardiac output, increased release of catecholamines. It initially improves the cardiac output, then too much, then it increases the oxygen demand of the heart with an increased workload. There's a neurohormonal response, which results in decreased renal blood flow, releases of renin, converts it to angiotensin 1 and 2, releases aldosterone, and their sodium and water retention, increased blood pressure, decreased cerebral perfusion pressure, secretion of ADH, and that increases water retention. And then counter-regulatory mechanisms, BNP, the brain natriuretic peptide, is released from ventricles in response to increased blood volume in heart. Causes of heart failure and risk factors include hypertension, coronary artery disease, congenital heart defects, inflammatory and valvular heart disorders, cardiomyopathy, diabetes, advanced age, smoker, obesity, high cholesterol, and genetics. Clinical manifestation depends on the type, and we're going to talk about those in just a minute. Left-sided, so heart failure can be left-sided or right-sided. Left-sided leads to pulmonary congestion and edema, or your symptoms are of pulmonary congestion and edema. Right-sided is more fluid overload, or poor venous return. So you get JVD, hepatomegaly, and splenomegaly, vascular congestion of the GI tract, and peripheral edema. Diagnostics is based on their history and physical. They want to determine the underlying cause. They'll do a chest x-ray. They'll do BNP, serum chemistries, cardiac markers. They'll do hemodynamic monitoring. Specifically, they're looking at the filling pressures, 2D echocardiogram, and nuclear imaging. We're going to treat the underlying cause, oxygen, daily weights, and we need to notify the patient needs to notify the physician for weight gain, sodium, restricted diet, medications, and we'll talk about, and possibly a circulatory assist device. Acute decompensated heart failure is left ventricular failure that results in engorged pulmonary vascular system. The lungs become less compliant. They get tachypnea, they get crackles, develop respiratory acidosis. If it's progressive, it manifests as pulmonary edema, which we talked about in respiratory, but it's an acute, life-threatening situation. And signs and symptoms include anxiety, pallor, cyanosis, cold and clammy skin, dyspnea. Respiratory rate will become greater than 30. They're using accessory muscles. They have frothy, blood-tinged sputum and adventitious breath sounds. Chronic heart failure is a progressive worsening of the ventricular functioning and chronic neurohormonal activation, which causes the ventricle to remodel. Um, Fatigue, dyspnea, um, tachycardia, edema, nocturia, skin changes, behavioral changes, chest pain, weight changes are symptoms, and complications are pleural effusion, dysrhythmias, left ventricular thrombosis, hepatomegaly, and renal failure. Um, Heart failure is classified based on usually the New York Heart Association is one way of doing that, and that's based on tolerance to physical activity. The American College of Cardiology and the American Heart Association have a staging system that identifies disease progression and treatment strategies. It allows for identification of people at risk for heart failure, but don't currently have heart disease. There are studies that demonstrate that if we can eliminate, like there's a huge um, savings to the healthcare system, to the patient, and if we can reduce the heart failure admissions. Um, Collaborative care in acute decompensated heart failure, we want to measure the LV function, and so we may have to put in pulmonary artery catheter for that. High Fowler's position, oxygen, BiPAP, circulatory assist device is a possibility. They may need to be mechanically ventilated. We're going to do vital signs and urine output every hour, hemodynamic monitoring, as I said earlier, medications, and we'll talk about those in a minute, possible cardioversion if they have atrial fibrillation. They may do ultrafiltration for volume overload, and that's a type of dialysis where they're just removing excess fluid. Chronic heart failure, we're going to do oxygen, we're going to do rest activity periods. So make sure that we do give them periods of rest. Medications, they might need a left ventricular assist device, cardiac transplant, and palliative care. When we're talking about inflammatory and valvular diseases, there's some terminology we need to talk about. Subacute endocarditis is a longer clinical course, affects those with pre-existing valvular issues. Less toxic, and it's usually caused by streptococcus. Acute endocarditis is a rapid onset to a previously healthy valves. Shorter course of treatment, very toxic. Staph aureus is the usual causative organism. Vegetation is how it's described when there's a primary lesion caused by fibrin, leukocytes, platelets, and microorganisms sticking to the valve surface or endocardium. Vegetation, is important to know, can become emboli. Pulsus paradoxus is a drop in the systolic blood pressure during inspiration of greater than 10 millimeters of mercury. It's exaggerated in cardiac tamponade. And chronic constrictive pericarditis is secondary to neoplasms, radiation, surgery. Sorry, it should have like a comma in there. Undetected pericardial effusion, which leads to scarring. The pericardial sac then has limited motion. It mimics heart failure and cor pulmonale. They get dyspneic on exertion, edema, fatigue, precordial knock, a loud early diastolic sound heard on the left sternal border. More terminology, we have regurgitation, which is an incompetent closure of the valve resulting in the backward flow of blood, and it's also known as incompetence or insufficiency, or stenosis, which is a constricting or narrowing of the valve. So the valve doesn't open all the way, and so not enough blood can get through. Diagnostics for valvular heart disease, again, we'll talk about their history and physical. In this case, we want to know also their dental history, if they had childhood diseases, because sometimes that causes some rheumatic heart problems. CT scan, chest x-ray, CBC, EKG. They'll do an echocardiogram. They want to see if there's regurgitation or stenosis, if there's a backflow of the blood, and they'll do cardiac cath. In collaborative care, we can do conservative treatment or surgical treatment. Conservative treatment, we would do prophylactic antibiotics for dental procedures, restrict their sodium. We'll treat them as though they have heart failure with vasodilators, ACE inhibitors, inotropes, etc. Um, they may do a percutaneous balloon valvuloplasty or a percutaneous valve replacement. There is a lot more. This is for usually for patients who've already had valve replacement called TAVR. We see that at St. Joe's and probably other places as well. But basically, they're going in through the cardiac cath lab or PCI and replacing the valve that way instead of it being an open heart surgery. They may do an open heart surgery and surgically replace it. They may try to repair the valve, doing a commisurotomy, a valvuloplasty, or an annuloplasty. And basically, what they're trying to do is repair the leaflets or tighten them up a little bit, depending on the problem. They may do replace the valve completely. They'll either use biologic tissue valve, which is usually porcine, or a mechanical valve. And they'll base the decision on the patient's lifestyle because the mechanical valve requires lifetime of anticoagulation, and so then they're at risk for bleeding. They need to have frequent lab work. There are clot eluting valves, but they still need to be on a Coumadin or something like that. Tissue valves don't require the anticoagulation unless the patient has atrial fib, but they require replacements more frequently. So the decision will be very patient specific. The most common valve disorders, the mitral valve is often can be stenosed or have stenosis. What happens if it's stenosis, it blocks the blood flow from the left atrium and the left ventricle during diastole. There's high pressures in the left atrium, clinical manifestations, dyspneic on exertion, loud S1, and a murmur is most common. They may also have hoarseness, fatigue, hemoptysis, and chest pain. They can also get regurgitation. An acute regurgitation would have a murmur, pulmonary edema, cardiogenic shock, chronic fatigue, and dyspneic on exertion. An S3 and a murmur. Prolapse, so the valve isn't functioning well at all, is a broad range of severity, palpitation, syncope, chest pain, dyspnea on exertion, murmur, it's usually benign and manageable. And the aortic valve can be stenosed or cause regurgitation. In stenosis, there's angina, syncope, dyspneic on exertion, heart failure, murmur, and an S4. And regurgitation, acute abrupt onset, chest pain, left ventricular failure, cardiogenic shock, chronic fatigue, dyspneic on exertion, murmur, S3 or S4, water hammer pulse. Inflammatory diseases include infective endocarditis, and this used to be fatal with antibiotics. Since the introduction of antibiotics, our mortality rates are now about 20 to 40%. Antibiotic prophylaxis is indicated for anyone needing dental care or surgery with certain cardiac conditions. Causes are age, valve replacements. IV drug abuse is a big cause of it, and it can be either bacterial, virus, or fungus that causes it. Clinical manifestations, your favorites: vague, fever, chills, weakness, malaise, fatigue, anorexia. New onset of a murmur. They can have arthralgia, back pain, weight loss, clubbing, splinter hemorrhages, Osler nodes, Janeway lesions, and Ross spots. Diagnostics include dental. We need to get a good dental history, blood cultures, echocardiogram, chest x-ray, and ECG. Treatment and interventions, we want to ID the organisms, or the causative organism. Bacterial, they'll give IV antibiotics for 4 to 6 weeks. And they'll likely need a PICC line for those IV antibiotics. Fungal, they may do a valve replacement and treat with antifungal. Pericarditis is complications of pericarditis include cardiac tamponade and pericardial effusion. Etiology, adults, it's usually idiopathic, can be viral. They could have uremia, bacterial infections, could have an MI, which is one of the most common causes of pericarditis, TB, post-cardiac surgery, or trauma. Clinical manifestations, they present like they're having an MI, so they're having chest pain, they're having shortness of breath, they can be tachypnic. Hallmark finding is the pericardial rub, pain over the left chest, and it radiates to the neck, the jaw, and the arm. Again, we're going to look at the dental history, but the big thing will be the ECG. We're going to do the other things, but the ECG, they'll have ST elevation in globally across all the lobes, all of the leads, sorry. Again, we want to ID the cause. They'll have antibiotics, likely have corticosteroids and NSAIDs that will help to reduce that inflammatory process. They may get an increased dose of aspirin or indomethacin, and they may need a pericardial centesis. Dilated cardiomyopathy, there's different types of that, of cardiomyopathy. Dilated causes are toxic agents such as cocaine and alcohol. Coronary artery disease, it can be genetic. There's a whole list of symptoms, and they're all very familiar. They would have moderate to severe cardiomegaly, decreased contractility. They'll be tachycardic and may have atrial and ventricular dysrhythmias and a decreased cardiac output. The goal of the treatment is to control the heart failure by enhancing myocardial contractility and decreasing preload and afterload. So we're going to treat with medications such as nitrates, diuretics, beta blockers, etc. End stage for dilated cardiomyopathy would be a transplant. Hypertrophic cardiomyopathy causes are aortic stenosis, can be genetic. Hypertension. Clinical manifestations include exertional dyspnea, fatigue, angina, syncope, palpitations. You can see that it can be mild to moderate. They can have mitral valve problems, atrial and ventricular dysrhythmias, normal or decreased cardiac output. The goal is to relieve the left ventricular outflow obstruction, so we would probably do beta blockers or calcium channel blockers, digitalis or digoxin for atrial fib. They may need AV pacing, surgery to remove some of the ventricular muscle. We want to avoid strenuous activity and dehydration. And in this case, if they have hypertrophic cardiomyopathy, if they're given a vasodilator, that may worsen their chest pain because it decreases venous return. Finally, restrictive cardiomyopathy causes are amyloidosis, endomyocardial fibrosis, neoplastic tumor, post-radiation, sarcoidosis, ventricular thrombosis. Manifestations include dyspnea, fatigue, mild cardiomegaly, and you can see the list goes on. Normal or decreased cardiac output, and there's no specific treatment goal. The goal is to improve diastolic filling. And that's the end of this PowerPoint.